Hello, and welcome to your online lecture for foot and toe assessment. We are going to break this lecture down into a two-part series. Part one of the series will be on anatomy and really truly understanding the anatomical structure that are the foot and the toes. This will become important because if you learn nothing else from the gait and static posture lecture, is that the foot is the foundation of the human body. In other words, it's the first point of contact when we get out of bed, but more importantly, every joint proximally to that sits on top of it. So if there's any type of breakdown in the anatomy, in the structures, then essentially everything else will break down in the kinetic chain. So it becomes important to understand the anatomy, which is why we're breaking anatomy and pathologies apart for this two-part series. The first part of this lecture, what we're really going to start with and focus in on are the movements that can occur about the ankle and the foot. We know for a fact that there are three planes that motion can occur in. The first plane is sagittal plane. The second plane is the frontal plane. And probably the plane that we operate within the most is going to be the transverse plane, right? We can kind of couple those motions to their actual planes. And so what we can say is that dorsiflexion and plantar flexion of the ankle, along with toe extension and flexion, are going to occur in the sagittal plane of motion, right? We can then further say that inversion and eversion of the foot and ankle are going to occur about the frontal plane of motion. And then what we know is that we have these more complex coupled movements known as pronation and supination, and those motions are going to occur about the transverse plane of motion. So we have this dorsiflexion, plantar flexion, toe flexion, extension moment that's going to occur in the sagittal plane. We have inversion, eversion occurring in the frontal plane, but probably most often in the foot and the ankle, what we see is this coupled motion of pronation and supination, and that occurs about the transverse plane. So now that we have a little bit of an understanding of the motions that occur at the foot, I think it's important before we dive deep into the anatomy to talk about the role and the toes. And so there are really two major roles that the foot plays within the human body. The first role is stability, and then the other role is mobility. So the opposite of stability, essentially, right? So what do I mean when I say stability? The foot becomes stable. And when the foot becomes really stable, or another way to say that is rigid, what we see happening is that foot becomes a rigid lever. And when it becomes a rigid lever, it prepares us, the body, the human, to actually propel, right? To be force producers, if that makes sense, right? And so a stable foot allows it to become rigid and then allows for propulsion to occur. And this will become important in ballistic sports where you need to jump really quickly, in sports that require speed like track and field, right? Where you want that foot to be extremely rigid so you can have more propulsion and be a faster lever, essentially. And so what we know about the foot being extremely rigid and or stable is that it creates this dynamic support for the foot, right? So when our foot is stable, we're supported, right? That makes sense. It's tight. It's not moving anywhere. It's almost immovable, for example. When we translate that over to the gait cycle, right, what we know is that we have basically two phases in the gait cycle, the stance phase and the swing phase, right? So you might say, well, how can I translate that over to the gait cycle? Well, at what point in the gait cycle do we actually see a rigid foot? Because this is what's important and key when you're taking information and translating it over into clinical practice, right? So a stable foot is most important during heel strike. Can you see that? During terminal stance, during pre-swing, and then again at terminal swing when the foot is touching back down. You can see that the foot has to be rigid to allow us to either propel forward, right? Or to allow us to kind of slow down from our actual swing phase. So when you're thinking, okay, when I'm watching gait, what should I be seeing the foot behave like? Well, in heel strike, terminal stance, and pre-swing, we should be making sure that that foot is able to get into a supinated rigid position to allow us to propel, right? More importantly, during that pre-swing phase where we're kind of catapulting over into the stance phase of life. On the opposite end of that, another important function of the foot is to become mobile, right? So we're in this rigid state. We're really tight, which is good. We're a rigid lever. But at some point in time, we have to transfer force and we have to become a mobile foot. And a mobile foot is important, most important, for two reasons. Number one, it allows the foot to adapt. So just think about different surfaces here. If you're at the beach and you're walking or strolling along the beach, your foot has to be able to adapt to the different pits and holes that are in the sand, right? We're able to do that because the foot is able to become mobile and allow us to adapt. Just as much as if we're walking in grass or we're walking, I don't know, let's say on cement, the foot has to be mobile enough to adapt to the surface that it's being placed on, right? And then finally, within the mobility family, the foot is a shock absorber. When the foot is mobile, the foot is a major shock absorber, which is great. We need to take ground reaction forces from the actual ground itself and transfer it up through the kinetic chain. Guess how the foot does that? It does that by becoming mobile. So what movements of the foot do we associate with stability? And then what motions of the foot do we associate with mobility? If you are a stable foot, most often you're going to be in a supinated position. Because in a supinated position, this is when the foot is most rigid. If you are a mobile foot, and you're ready and ripe for shock absorption, then you're probably most likely going to be in a pronated foot position, right? And each of these foot positions are okay as long as we don't spend too much time in either supination and or pronation. But back to mobility, where do we see the foot being most mobile, or where in the gait cycle do we want the foot to be most mobile? It's during the loading and the mid-stance phase. We want that foot to pronate, to become more mobile, to absorb any ground reaction forces, and then we want it to be rigid all over again to allow us to propulse. So you can see how knowing the role of the foot and toes becomes important in our static posture and becomes even more important as we're assessing gait in our patient. Now that we understand the roles of the foot, let's segue into the of the foot and the toes. And maybe all of you know this, but I am always in awe of how many anatomical structures live within the foot joint and the toe joints. So what we know about the foot is it has 26 structural bones, right? So 26 bones, 2 sesamoid bones, 33 joints, 107 ligaments cross the foot, and then 19 muscles. Wow, just 19. So is the foot a muscular structure? No, it is an extremely bony structure, which is supported a lot by its ligaments, which means if we're going to see injuries to the foot, most often those aren't going to be strains. Those are going to be sprains of the ligaments that attach to the foot and hold that foot intact. So I hope you guys are kind of connecting the dots that if an injury to the foot's going to occur, it's going to be bony in nature, or it's going to be to the joint, and a sprain will actually occur to that actual foot, right? So we've got clinical anatomy, we've got the way the foot actually functions and its roles. But one thing that we have to consider is that the foot is actually divided into 3 components. And this becomes important more so during gait than during your static postural assessment. But there are 3 divisions of the foot. The first position is the forefoot. As the name implies, it's the front of the foot. The forefoot is comprised of really 2 types of bones. Those are going to be your phalanges and your metatarsals. So your phalanges are the distal bones, and then your metatarsals are the long bones of the forefoot. Then you have, it's broken down into your midfoot. Your midfoot's important, right? Because your midfoot is going to contain the tarsal bones. So here, the tarsal bones, so it's going to contain cuneiform number 1, cuneiform number 2, cuneiform number 3, the cuboid laterally, and then the navicular medially, right? So we have our tarsal bones being formed within the midfoot. And then last but definitely not least, we have our rear foot bones, right? Which are the talus and the calcaneus. So that large calcaneus here, and then that smaller talus, which is going to sit on top of the calcaneus. So we can see that when we're looking at gait, we have to look at a few things. How does the forefoot function? How does the midfoot function? How does the rear foot function? And then even more high level 3,000 foot view would be, how do all 3 of the divisions of the foot work together to make the foot stable and then to allow it to become a mobile structure to absorb some of the shock or forces that are going to be going across it, right? So let's break this down a little bit further. When we look at the rear foot in particular, we said that the rear foot was comprised of the talus and the calcaneus, right? And we can kind of see the relationship between the talus and the calcaneus. It sits just proximal to that calcaneus, and it's a tight-knit joint. It's a tight-knit structure, right? So as we're looking at this structure, one of the important things to really consider, and here's where we talk about the ankle joint without talking about the ankle joint, is that the rear foot really is also formed by other anatomical structures that we'll talk about in detail in the ankle, but we kind of have to mention them here. So the fibula and the tibia, right? We know that the fibula and tibia articulate with one another distally to form the tibiofemoral joint, right? We see that here. But then what we also see is this articulation between the talus and the tibia. And this is what connects the ankle joint to the foot joint. So I hope you're seeing that. But structurally, let's just do a quick review anatomically. The ankle mortise is made up of the lateral malleolus, the medial malleolus, the talus, and the calcaneus, right? So when I refer to the ankle joint in a few weeks, you guys are going to say, Dr. Cosby, the ankle joint is formed by the fibula laterally, the tibia medially, the talus, and the calcaneus, right? And it is these four bones that work together to make that foot a stable or mobile joint structure. In particular, early on in that the stance phase of gait, right? So we already talked about this. We said in that mid stance is where I think foot mobility is probably most key and most important. It's these structures right here that we see on this slide, these four anatomical structures that are going to work to allow that foot to get into a stable or a mobile position, right? But look at joints of the rear foot, because I think it's important to not only just define the ankle mortise, but then to talk about the joints that are actually formed between the articulation of these four bones. The first joint is an ankle joint, and it is the talocrural joint. As you can see, that talocrural joint is formed by the articulation of the talus here with the distal tibia and fibula. So it is these three structures right here that make up your talocrural joint. This is huge, you guys, in understanding ankle mechanisms. But again, we'll talk about that in a few weeks. The next joint that's distal to that is the subtalar joint. And the subtalar joint, what we know about it is that it's formed between the articulation between the talus and the calcaneus. And sub meaning below something, right? So that subtalar joint is below the talus, right in here. It lives right in here. That talocrural joint lives right in here. It's the articulation between this bone, and that. And then your subtalar joint is going to be the articulation between the talus and the calcaneus, right? And these joints are important because if the ankle gets injured, most often the first joint to get compromised is the talocrural joint, and then secondarily would be the subtalar joint. And if that happens, then the foot's ability to either be stable or mobile becomes compromised, okay? As we discuss supination and pronation movements, I've said it occurs in the transverse plane of motion, and I've said they're coupled movements, right? What we know about the subtalar joint in particular is that this is where those motions are going to occur, right? So that subtalar joint, it represents the articulation between the talus and calcaneus, right? We just defined that on the other slide. And what we're saying is this articulation, right? This joint is responsible for producing our coupled motions of pronation and supination. So if we define pronation, which is the foot flat position, the position in which you're going to absorb all of your shock, the position in which the foot is most mobile, then what we could say is that it's dorsiflexion at the ankle coupled with abduction of the calcaneus and eversion of the foot. Do you like how I described that? Dorsiflexion of the ankle, abduction of the calcaneus, eversion of the foot. If we want our foot to become a very rigid structure, then that's going to be a supinated motion, and that's the opposite of pronation. So it's going to be foot ankle pronation, calcaneal adduction, and inversion of the foot, right? And that's how we get into that supinated position or that rigid foot position, right? Okay, as we continue on and we move from the rear, going to move into the midfoot. And I said the tarsals are responsible for making up the midfoot of the foot. And so with that said, on the most medial side of the foot, we have the navicular bone, right? Which is right here. And then essentially we have the first or medial cuneiform, second or middle cuneiform, third or lateral cuneiform, right? And then we have the cuboid bone right there, and the navicular here. And so these bones are important because when the foot becomes mobile, you're tracking? When the foot becomes mobile, essentially it's these bones in the midfoot that unlock and allow the foot to go into pronation. Say what? Like, think about that. These bones, the navicular, the cuneiforms, the cuboid, they unlock and allow the foot to become mobile. So they are what we call the shock absorbing segment of the foot, because they are responsible. They are the key to the foot. They allow the foot to unlock just as much as they control the foot locking or becoming a stable structure all over again, right? Okay, so there are the midfoot that become extremely important to remember. The first is the talo-navicular joint. So if I say that to you guys, right, then you guys should all say to me, okay, it's the articulation between what? The talus and the navicular. So if I was to draw that in to this image here, you would all say to me, okay, this is the talus, this is navicular, so that joint must live right here. This is the talo-navicular joint. What we know about the talo-navicular joint is that it is a major supporter to the medial longitudinal arch. So if I were to draw that medial longitudinal arch in, you'd see it be right here. It's a major supporter to that medial longitudinal arch. On the lateral side of the foot, we have the calcaneal cuboidal joint. So just think, this is the end of the calcaneus. This is the cuboid. So that calcaneal cuboidal joint is going to live right here. And what we know about this joint is it supports the lateral longitudinal arch, right? So if we were to draw in that lateral longitudinal arch, it would exist there, right? What we know about the last joint that we're going to talk about, which is circled on the slide, is the tarsal metatarsal joint. That is the articulation between the distal tarsals and the proximal metatarsals. See that there? And it is called the Lisfranc joint. Most often what we know about this is it allows the tarsals and the metatarsals to glide across one another. Again, it's responsible for allowing the foot to compensate or to adapt to uneven terrain. So let me say that to you this way. If we're walking on sand and it's bumpy, the reason your foot can adjust is because of that tarsal metatarsal joint. It's because those tarsals and metatarsals glide against one another and say, oh goodness, I'm on an uneven terrain. Let me shift or let me glide a little bit so my foot's more comfortable. So if we have disruptions in either of these three joints, so the talo-navicular, the calcaneal cuboidal, or the tarsal metatarsal, we could see how certain aspects of the foot will be thrown off. In particular, our ability to become a mobile structure, our ability to absorb the shock that's coming about the foot itself. So there are two ligaments that are vitally important to the structural integrity of the midfoot, and one of them is the bifurcate ligament, or I call it the Y-shaped ligament because of its actual size and shape. And so in gross anatomy, if you're able to dissect the foot down to this level, you'll see that it has a Y-shaped appearance. And so it's called the bifurcate ligament, but a lot of anatomists also call it the Y-shaped ligament. It's a Y-shaped ligament for this reason, and it has to do with the anatomical structures that it's connecting. So the first part of this ligament will connect the calcaneus to the cuboid. So since we're on the lateral side of the foot, I went with that first. So it's going to have a connection to the calcaneus and the cuboid. And you can see that here in number 14. And then the second part of that ligament is essentially going to bifurcate off of, right? You see that? Its own ligamentous attachment, and then segue over onto the medial side. So it's going to connect the calcaneus to the navicular, right? So it has two attachment points. And I think this is an important concept because the cuboid and the navicular are huge components to maintaining either the medial longitudinal arch, which would be the navicular, right? Or the lateral longitudinal arch, which is the cuboid. So this bifurcate ligament, when we're thinking about its structure, its role in structural integrity of the foot, it's basically one of the primary ligaments, because what it does is it attaches to the primary weight-bearing portions of the foot, which are the cuboid on the lateral side and the navicular on the medial side. And so if it gets injured and stretched, then we can lose some of the structural integrity across the foot. In particular, it's going to assist in stability and in making the foot drop down into a mobile structure. If they get strained or sprained, what we typically will see is that that foot just becomes more mobile and spends more time, listen to me, more time in a mobile position, which means it's absorbing way too much shock. So this bifurcate ligament is important in the midfoot structure. The other ligament that's important in the midfoot is on the medial side of the foot, and it's called the spring ligament, or as your textbook might allude to it as the calcaneal navicular ligament. And it gets its name from what it attaches to and from, right? So it attaches medially to the calcaneus and the navicular, right? And its major role is to provide more support to the medial longitudinal arch. You can tell that the medial longitudinal arch is an important anatomical structure. And so the key to this is it is a spring, which is why it got its name. When they went deep into dissection and they started to look at foot behavior, what they found is that this spring-like ligament either lengthens to allow the foot to become mobile, but then in the portion of the gait cycle, what we see is that it springs back from its lengthened position to a shortened position and allows that foot to become rigid and to propulse, right? So it's like a spring, essentially. If it gets stretched, we lose that springing ability, which means that foot stays in a mobile position longer and it's not able to spring back into a stable position, which means they just won't be good at force propulsion, right? Which can be good for some people. If they're not sprinters, if they're not performing ballistic sports, then maybe the spring ligament isn't important. But for those sports where you're working with runners who sprint, exploding out of blocks, basketball where they're exploding on a single limb for a layup, you get my point, right? That spring ligament is huge. Its function, its integrity is absolutely important to the structure of the foot. Okay, now we move into our forefoot structures. On the forefoot side of the house, we have the phalanges and we have the metatarsals. So we have 5 metatarsals, we have 14 phalanges, a great toe, and 2 sesamoid bones, right? And those sesamoid bones, just like any sesamoid bone in the body, their job is to increase the mechanical advantage of the pull of a particular muscle. In this particular case, it's the flexor hallucis muscle, right? The ability of the toe to move into a flex position. So forefoot wise, these are the bony structures. The major role of the forefoot, what I would say, quite honestly, is its ability to get us into like the toe off phase or terminal swing phase of gait. Let's take a look at the joints of the forefoot, because just like the joints of the midfoot, these joints are extremely important, or just as important as the midfoot joints. So we have the metatarsal phalangeal joints, which to me, I kind of equate them to like the knuckles in the hand. So you have your metatarsal phalangeal joints, which essentially represent what? The articulation between the metatarsal and the phalange, right? What we know about the phalanges is that the first ray only has an interphalangeal joint and it doesn't have a distal or a proximal. But digits 2 through 5 have a proximal interphalangeal joint and a distal interphalangeal joint. What's the main function of the joints of the forefoot? It's stated here, right, in this slide. It's to allow the foot to rotate over the toes. And this becomes important when you're like in that toe off phase of gait and you're getting ready to propulse. So in one way, I like to think of these joints as very crucial to making sure that the foot continues to maintain stability so that it can act as a force producer or a propulsor. Moving forward, let's talk about the plantar fascia. The plantar fascia is becoming one of my favorite anatomical structures the more and more that I read about it and learn about it. So when we think about the plantar fascia, I love this image here where it depicts what it does, right? The plantar aponeurosis or the plantar fascia really has 3 slips. It has the the lateral slip here, it has its medial slip, and then it has its most central slip, right? What we can see, regardless of the slips, is that they all kind of have this attachment onto the metatarsal heads, and then they all come down and attach to that medial calcaneal tubercle. The major role of the plantar aponeurosa is massive amounts of foot stability, right? To provide foot stability and to act like a spring. What we know through dissection is, number one, there's a large fat pad that exists within the foot, and this is intentional, right? Because the foot is such a bony structure, I always like to reflect on how God created us. And when I look at some of the joints, like deeply, oh man, I love the way that we're created and we're distinctly and uniquely made, right? Look at this fat pad. This fat pad is thick. It's one of the thickest fat pads in the human body, but it's there for a reason, right? The reality is the foot makes the most contact with the ground. So look at this. We have this fat pad that's protecting us because someone knew, I wonder who, someone knew that we would be contacting the ground a lot. And so someone gave us cushion, right? You get it? Okay, so we have this fat pad that protects the foot. And then we have the plantar aponeurosis, which is hugely important for stability of the foot in particular. Its major role is to work with the foot intrinsics, right? And we know the role of the foot intrinsics is what? To provide stability of the foot, to make sure that foot can become a rigid lever, to provide support to the medial longitudinal arches, right? Tons of roles of the foot intrinsics, and you guys learn those. I hope memorize them in gross anatomy. If not, here's your chance to re-memorize in. So what's new and what am I adding about the plantar fascia? It's this concept called the windlass effect. What we know about the plantar fascia is what I said on the previous slide, is that it has attachments to the metatarsal heads of the foot. What we know happens with this plantar fascia is that when the toes extend, if the plantar fascia is intact, when those toes extend, what's going to happen is that plantar fascia is going to draw the calcaneus towards the metatarsal heads, making the foot a rigid structure. Does that make sense? So toe extension causes the plantar fascia to drag those metatarsal heads towards the calcaneus, making it the rigid supinated foot that we need it to be. Okay, that's during toe extension. And this is called the windlass effect. It just happens naturally. You don't have to think about it cognitively. When you extend those toes, if the plantar fascia is intact, the calcaneus is going to draw closer to the metatarsal heads, which allows that foot to become extremely stable. When we look at this next slide, it's just another depiction of how the plantar fascia actually works, right? And what I want to do is really look at it from a gait standpoint. So if we're looking at this image down here, anytime you see that toe and extension, that plantar fascia is going to draw those metatarsal heads toward the calcaneus, and you can see we have this rigid-like structure, right? Again, here in toe extension, we're going to see the same thing happening. Those metatarsal heads are going to draw back to that calcaneus, making that foot an extremely rigid structure. I'm sure you're tired of me saying extremely rigid, but it is important when we talk about plantar fasciitis, because when we get to pathologies, if you have a patient who has plantar fasciitis, it will impact the windlass mechanism. It will impact their ability to get into a rigid position, and they will spend more time in a foot flat position, which increases the amount or number of chronic injuries that we'll see in our particular patient. So the role of the plantar fascia becomes important, in particular, its role in the windlass mechanism. Okay, so I've mentioned arches a lot, but now that we're in an advanced class, it's important to know which anatomical structures actually make up the arches of the foot. So we have the medial longitudinal arch, we have the lateral longitudinal arch, and then last but not least, we have the transverse arch. I think I'm going to start with the transverse arch first because it's the simplest of the arches to actually understand and to comprehend. The transverse arch is formed by the cuneiforms and the cuboid. So we can imagine if we could draw in an arch right over that midfoot, that would be the transverse arch. But it also includes the navicular and the tendon of the fibularis longus, right? Because it's the longest tendon that's going to come around. Remember, it's going to come around the lateral side, dive under the plantar surface of the foot, and then have that attachment to the first ray. So that transverse arch has at least 4, you could add 5 bones included in its genetic makeup, right? Now let's move to the lateral longitudinal arch, which is here. We can see that the lateral longitudinal arch contains the calcaneus and the cuboid for sure. It contains all of the metatarsals 4 and 5. Okay, and then last but not least, there are lots of ligaments that are also make up the lateral longitudinal arch. The fibularis longus and brevis are the muscles. Plantar fascia, at least the lateral part of the plantar fascia will, and many of the lateral muscles of the intrinsics of the foot will also do that as well. And then last but definitely not least is the medial longitudinal arch. And I think this is probably where we spend time because it's the medial longitudinal arch that most often gets compromised. And so it is made up of metatarsals 1 through 3, the talus and the calcaneus, right? It also contains the navicular. So I have to think about this, medial cuneiform, okay? In addition to that, we have the spring ligament, which I told you was important for the structural integrity of the medial longitudinal arch, the medial plantar fascia, tibialis anterior and posterior, which both have attachments on the medial side of the foot. And then we have the flexor hallucis longus and fibularis longus, right, which dives down plantarly and attaches to that first ray. So we can see how we have some crossovers between what's being shared between the arches, but by far in terms of integrity, structural integrity, we can see that that medial longitudinal arch is held together by several anatomical structures. And if one of those components gets injured, then the entire medial longitudinal arch can actually fall apart. And if one of those structures gets injured, what we know is we'll spend more time in a foot flat position, right? And so if we're looking up here, we can see the transverse arches, we can see the medial longitudinal arch and the lateral longitudinal arch. This is important for you guys to know for your BOC. Hint, hint, hint. So what are the roles of the arches? We've talked about the roles of the foot, right? We said 2 key roles. There's stability and then there's mobility, right? Okay, so how do the arches play a role in foot stability and mobility? What we know about the stability component is that the arches kind of help distribute the weight throughout the foot. And then they help convert the flexible foot, the mobile foot, to a rigid foot. So their major role really, in my mind, is just making sure that that flexible foot can become rigid when it's ready to become rigid. On the opposite end of that, we have the mobile foot, right? And the role of the arches in the mobile foot is to relax enough or unlock enough, right, that we can dampen the impact of weight bearing and distribute forces up the kinetic chain. Does that make sense, guys? So we can see how the arches play a huge role in the foot's ability to function like it's actually supposed to function. On the next slide, I'm showing you this. It's taken from your textbook. You should have learned this already, but if you haven't, here are the 4 intrinsic layers of the foot. What we know about the intrinsic layers of the foot is they provide most of the stability. Remember, there aren't that many muscles in the foot. This makes up probably 90% of them. Becomes important to know them by layer, but ultimately as a whole, right, these muscles provide stability to the foot and structure, right? And so when they do those 2 things, when they get injured, we lose the ability to become stable. We lose the structure. Ground reactional forces then adjust and change, okay? Now, we've talked about anatomy. I have a few slides on the evaluation process before we get into pathology. So what to remember in the evaluation process for the foot. We've already been over history 1,000 times. So now I'm being more foot specific. These are history questions that you're going to be asking in an evaluation process, right? Okay, so in terms of foot evaluation, what we want to think about in the way that I think about it is SINs, the severity of the injury, the irritability of the injury, the nature of the injury, and the staging of the actual injury itself, right? And so when we think about severity, what we're thinking about is how does it impact the patient's life? That's just a simple question. Can they walk? Can they do this? Can they do that? What can they do exactly? In terms of irritability, what we want to know is how stable is the condition or how reactive is the condition? So what does the patient do to set off that pathology? Once it's set off, how long does it take? And then what does the patient have to do to kind of reduce those signs and symptoms all over again? In terms of nature, is it the numbness, tingling, weakness, popping, so sound, sensations? And then last but not least is stage. The stage is, has the condition stabilized? Has it become stagnant or stayed the same? Has it deteriorated or gotten worse over time? Right? Those are questions you want to ask patients with foot pathologies who are coming into your clinic. History questions that you should think about when a patient with a foot injury comes into your clinic is, does spinal motion actually cause foot pain? Do certain postures in the upper extremity impact the signs and symptoms? So you see how we're going away from the foot and asking up the kinetic chain. We want to know about stiffness first thing in the morning. That's typically associated with plantar fasciitis. Same thing with the heel hurting. And then shoe preferences. And shoe preferences are important because what we want to know is that patient in an actual shoe that they should be in based on their actual foot posturing, right? We'll always have our patient bring in their shoes into the clinical setting so we can take a look at them. What we know about patients who either are hypersupinators or hyperpronators is you'll start to see wear and tear in certain aspects of the shoe if they're doing a lot of like scraping the toe, things like that. So weight bearing status becomes important. Can they bear weight? Can they not bear weight? Are they symmetrical in nature, which will be assessed by their actual gait itself? Is there any soft tissue swelling, effusion, atrophy, any plantar lesions, which tells us about wear and tear? And then you want to check for callus patterns, right? So do they have like a large callus pattern on their first ray? Is it on their fifth ray? That tells us where they're spending too much time. And then obviously shoe wear and tear. Okay, other things that we want to consider as we assess our patient is we want to take anthropometric measurements, which we'll do in the lab setting. But essentially, we want to assess swelling. We can do that with a measurement tape, or we can do it with a volumetric assessment. But this is extremely rare in the clinical setting. Most often, we're going to take out a measuring tape and assess ankle girth and foot girth in the clinical. Okay, we want to assess vascular pulses. Vascular pulses are extremely important. We always want to assess pulses distal to the actual injured site. And so we're going to assess the dorsal pedal pulse here, or we can assess the tibial pulse depending on. What I can tell you is that the tibial pulse is going to be a lot easier to palpate, but we'll do both in lab and you can decide which one you like better. We want to evaluate the foot, and this is going to become important, and this will be the last slide for this particular online lecture, is inspection. So we want to inspect the rear foot, and we want to look at calcaneal deviation. Do you see that there? Right? This tells us this is a supinated foot. You guys can see calcaneals deviated into abduction, so that's going to be a pronated foot. We want to look for bunions, right? See that there? We want to look for foot alignment. We want to look for discoloration about the toes. There's so many things that we want to look for when we are doing a foot assessment. This will kind of help us and tell us what pathologies we might be suspecting before we even begin our patient evaluations. So this is going to conclude the anatomical component to this online lecture. Part 2, which will be pathologies, will follow.